we run out of time. So, okay, welcome and a very warm welcome to this NOI Group clinical discussion. My name is Joanna Taylor and I am Director of NOI Group Europe, and I am joined this afternoon by NOI Group teacher and my very good friend, Ben Davies, Dr. Ben Davies. Welcome, Ben.
Hi, Joe. Hi, everybody.
So for those who have missed any of Ben's previous sessions, Ben is an advanced practice physiotherapist specialising in persistent pain and rheumatology. He brings over 20 years of experience teaching explain pain and has a gift for making the complex neuroscience accessible and immediately applicable. So Ben, it's great to have you back. Would you be kind enough just to tell the audience what it is that you are currently working on, please?
So I work in Bath in the UK. I work at the Royal National Hospital for Rheumatic Diseases, and we have a specialist, the only centre in the UK for axial spondyloarthritis. That's a rheumatological condition that leads to spinal stiffness, and we have a residential course that people can come and stay with us on site. And it's a multidisciplinary team of physios, OTs, podiatrists, a psychologist, and the medical team who try and equip that person to live well with axSpA. For all their life, because it's a lifelong condition.
Fantastic, thank you. Thank you for sharing that with everybody. These sessions are all about giving you a taste of explain pain and how to practically use it in the clinic. Some of you will have already done an explain pain course, and for those of you who have, this session will reinforce what you have already learned. But if you're new to explain pain, this is going to give you a little taste of what we cover in the core course. So Ben has an upcoming 2-day explain pain online course on the 9th and 10th of July. And if anybody is interested in attending or finding out more about that, we're going to give you some details about that at the end. So just hang back and you can find out more then. So just a couple of things to mention. We're going to be talking for about 20-25 minutes. If you have any questions, please drop them in the Q&A or in the chat, and we'll get to as many of them as you can. And if you want to watch the recording of this session, I'm dropping a link to the clinical discussion group where it will be uploaded a bit later on this afternoon. And there are about 60 other of these videos there too. And Ben does many of them on a whole range of different topics. So it's a great free resource. Please do go and subscribe, like, share it with your friends, colleagues. And it's a great place to go and find out loads about what we cover in Explain Pain. So today we're talking about when pain doesn't match the scan and how to reason through nociplastic pain. I knew this was going to be popular, Ben, when we released it. We've had a lot of sign-ups, so that's great. It's the clinical reality that many clinicians face. You have a patient sitting in front of you with significant pain, but their scans don't reflect it or are even completely normal. So could you explain what is going on neurologically when the pain doesn't match the imaging?
For all the clinicians on here, it will depend, of course, the kind of clinician you are, your profession, your work setting. But I guess part of our confidence is understanding what different scans show and what different scans don't show. Maybe if you mean by scan, let's broaden that to kind of imaging and the idea of objective imaging that medical services might provide. So X-rays are brilliant at bones, but that's pretty much all they show. So they'll show osteoarthritis, they'll show axSpA, they'll show erosions from rheumatology, but they'll show nothing else. MRI scans can be asked to show all the soft tissue, so we can look at disc bulges, and we can really good at finding age-related changes as you get older, that they're normal. They're really good at finding the cancers and the tumors and the fractures and the TBs, but they don't show pain. CT is different again. Nerve conduction studies will show is this nerve carrying information at a certain speed, but it doesn't show how much information is that nerve carrying. So I think as clinicians, we've got to have some confidence in understanding all those different modalities, and depending on where you sit, which modalities are you likely to come across? What modalities, if any, has your patient had in their journey to get to you? I think we should know what scans and imaging show, and we should also have some language about what they don't show. So MRI scans is, I suppose, the most common example. You have a pain somewhere in your body and you want medical services to image it. This will show me the problem, won't it? I've got to the scan, I've paid for the private scan. This is the answer now. I'm going to get that report and have that follow up with a clinician that says, this is the problem we were looking for. And the clinician, and people may well have had this experience when you go, it's good news, you've got a normal scan. Bugger, thinks the patient. I really wanted the answer to why I've got this pain. And now you're telling me there's nothing to see. What do you mean it's normal? Okay, well, scans don't show, they show that you don't have cancer, you don't have a fracture, you don't have ankylosing spondylitis, you don't have TB, but they don't show many things. And one of the things that none of these modalities shows pain. They don't show the activity in the nervous system, they don't show the experience of that nervous system. And I think we've got to have some language about articulating the pros and the cons, and the fitting this into the bigger clinical picture, which is, I suppose, one of your later questions, Jo. How do we fit the imaging into the whole jigsaw of the person sat in front of us? Their story, their experiences, their symptom descriptions, locations, what works, what doesn't work. Blood tests, perhaps, different kind of medical imaging in some way, but a different kind of objective testing. Imaging's part of that jigsaw. It's not the whole. So we've got to be able to articulate that.
Okay. So the second part of the question was, what is going on neurologically when the pain doesn't match the imaging?
So I think, what is the kind of pain that person's experiencing? We will have these labels, and as you said, Jo, nociplastic, I'm going to come back to in a second. Nociplastic perhaps is this newest term. IASP defined it, I forget, a few years ago, 4 or 5 years ago, this definite a new form of pain, a new subcategory of pain. The categories of pain clinicians on this call are probably most familiar with be nociceptive. Something's happening in my tissues. You know, the more I stretch this tissue, pretty much, the more it hurts. The more I put my hand on a hot plate, the more I heat my tissues up, the more I cool my tissues down. If those extremes of temperature carry on, this is going to do me damage. Inflammatory nociceptive pain. I've got inflammation in my tissues that are stimulating nerve endings, that are sending messages, that's making me feel achy and stiff, and I pay attention. Those patterns are going to have, that problem is going to have a certain pattern. Where does it hurt? What are the provocative factors in that person's experience? You know, if I do this, it hurts. And if I don't do that, it doesn't hurt. It hurts in the joint, or at least it feels like it's in the joint. So these are patterns for nociceptive mechanisms. Neuropathic, nerve-related, more likely to be related to the pattern that nerve supply, like ulnar nerve distribution. You could all now hit your funny bone. It's not a bone, it's a nerve. That gives you a certain distribution that is ulnar nerve. A certain nerve root impingement in your neck will give you a certain pattern into your arm. A certain pattern-ish. It's unlikely to look exactly like the textbooks. And neuropathic mechanisms tend to give certain descriptions. People will say, this pain burns, it itches, it feels like water's running down my arm. It feels like something's running up or down my arm, on my skin. Pins and needles, numbness. We'll leave central mechanisms, but we will allude to them. But nociplastic mechanisms are when this peripheral nervous system has become more sensitive than the default normal. So I've got nerve endings in here, I've got receptors that are sensitive to temperature, high temperature, low temperature. They're not usually sensitive to warmth. Put my hand in a warm bath, that doesn't stimulate nociceptors. It needs to be a hot bath or a cold bath. We have a level of sensitivity that, if you like, we've evolved through life, where we are paying due attention to our body through our experiences. But that peripheral sensitization, that peripheral awareness, can be upregulated. And then, I guess, the neurobiology is that the receptors at the ends of these neurons, the number of those receptors gets turned up. We produce more of them. The cell bodies that sit all the way up here produce more proteins that are nerve receptors. They travel down through the neuron, they get to the end of the neurons, and they get inserted into the terminal branches. So your immediate sort of senses out in your tissues, instead of being 3 out of 10 on a sensitivity scale, are now 4 out of 10 on a sensitivity scale, 5 out of 10 on a sensitivity scale. The pattern for this is everything begins to sort of be a bit more sensitive. It isn't so much pull to an extreme and it hurts. It's this now hurts. Even just moving my thumb, even thinking about moving my thumb, even the touch of light fabric on my clothing or from my bed sheets produces a noxious message that then, of course, you've got the whole spinal cord to consider, and then what the brain receives and what the brain interprets by that. It's peripheral sensitization. We'll often think about that as inflammation chemicals or injury creating peripheral sensitization, but it's that the receptors have become upregulated. Our periphery is now more sensitive to what might well be normal information about our body.
Brilliant. Thank you. Thank you for the distinction between nociceptive, neuropathic, and nociplastic. I think that it's still, so these terms are still relatively, not all, the nociplastic is still relatively new, I think. And that was really, really useful to understand the distinction.
And I think also it's really important that clinicians recognize, we read textbooks, we come to courses like Explain Pain, and there's sometimes a suggestion that, if you like, what is the pain mechanism for this person? Can we define the mechanism? I know David Butler would say, look, and people like Lorimer would say, look, all of these processes are happening. When I have a pain experience, some stuff is probably happening in my tissues and my nervous system, neuropathic mechanism, something's happening in my nerve and it's crossing my spinal cord. So central mechanisms are part of that, even if it's this acute, provocative pain test. And my brain's receiving that. So my brain is relevant. Am I super anxious about this bit of my body? Am I not bothered at all? Am I, what's going on up here? I think as clinicians, we need to, rather than use the word what pain mechanism, but what's the predominant, what's the sort of main pain mechanism? But you're going to have neuropathic mechanisms happen with everybody. You're always going to have a spinal cord contribution, and you're always going to have an emotional attention to the body or attention away from the body, a level of anxiety, a level of confidence, a level of self-efficacy. You're kind of trying to work out where's the predominant mechanism in order to perhaps think about treatment.
That brings us on completely to the next question, and that is about how do you assess and reason through whether a patient's pain is nociceptive, neuropathic, nociplastic, or a mixture of all three? Where do you start with that kind of thing?
So things like patient descriptions, really listening to the person. Those slightly throwaway words, perhaps. People might say, it sounds ridiculous, but it feels like ants are running down my arm. Yeah. I've heard that 100 times. Let me normalize that for you. That really indicates this is predominantly perhaps neuropathic. When someone says this pain is all over my body, all these scans you've done for me are normal, they've alluded to childhood trauma and adverse childhood events and difficult upbringings, and their mood really has an impact on their pain, and stress really has an impact on their pain, and drugs of all flavors don't really impact on their pain. We're going to kind of think, do you know what? I think this is predominantly central mechanisms. That doesn't mean it's all in the brain. It doesn't mean it's all in the spinal cord, but predominantly, they feel like that's where I need to aim treatment. But we've got to be mindful of the periphery as well. For nociplastic pain, and perhaps this is really common in things like fibromyalgia, again, it's going to be some degree of widespreadness. It's going to be some degree of lack of, almost like sensitivity to testing. If you're a physio, you're an osteo, you're a chiropractor, if you're doing manual therapy, if you're physically assessing the person, they're normal, their nervous system's normal, it works, it's not working. In fact, it's almost overworking. So things that sort of sense check how sensitive is your nervous system, some of those objective markers or objective tests or things that we do to people to elicit what we think of as truthful information can be really useful. But it's the
Yeah.
patient story, it's the normality of things like scans, which won't show nociplastic mechanisms. And
Yeah.
it's the implication of your physical assessment, probably
Mm.
finding that lots of things hurt.
Yeah. Yeah. Thank you. That's fascinating, Ben. Thank you very much. Um, and this brings us on to probably the bit that people often find the most tricky, and that is how we explain nociplastic pain to patients without how do we do that without reinforcing that it's all in your head or frightening them? What are some of the key points that we need to think about for this?
I mean, I know on these calls, these webinars before jobs, I will have said something similar, but I think
Yeah,
first of all, it's that validation to the person that
yeah,
what they're experiencing is what they're experiencing. That sense of trust that they need in you as a clinician. They need to know that you have listened, that you've understood, that you've acknowledged all the impacts that this is having on them. 1 second, have a quick drink. I think
I know
that
you may have
first,
said this before, Ben, but that happens a lot in these webinars because there's always repetition. I mean, it's all linked, isn't it? And sometimes we go into a lot of depth on this one subject. In fact, I think we've done a session in a lot of depth just on how to. It's not all in your head, but we'll just cover this at a high level today. Thank you.
okay. Yeah, I mean, acknowledging, validating, ensuring an empathic relationship, I think is key. Without that, you'll get nowhere. So
Yeah.
that's probably front and foremost. When they've come with the scans, that's the title of this session, isn't it? When they've come with those imaging studies, being equipped to say, look, these are the good things. This shows no damage, no cancers, no tumors. However, what it doesn't show is the reason for this pain. Now, that doesn't mean it's not real. And I would
Yeah.
just be overt and say, this doesn't mean it's not real. This doesn't mean this
Mm.
is, imagine psychosomatic, all in your head. What it's really good at doing is ruling out the nasties, but it doesn't show this. So in your jigsaw, we've got pieces here that are useful and pieces here that are maybe we need to fill in the gaps now.
Yeah.
The story, almost the whole life story of that person who's come to you. You know, they may have had a trigger that's initiated this pain experience, or at least it's brought them to your clinic. Could be a longer standing pain experience, but what's their history? What are their patterns of things that make this worse? If it doesn't have that clear mechanical aggravating and easing factor pattern, if it doesn't have a clear 24-hour diurnal inflammatory pattern, stiffness in the morning and eases with movement, if it has
Mm.
an unpredictability about it, or its aggravating factors are things like stress, mood, certain people, certain places, these things would be the things that would make your clinical spidey senses go, this feels like it's moving towards a nociplastic predominant mechanism. And they may allude to, again, depends on your profession, but they may allude to their moods, or
Mm.
have you got ways of asking about people's moods? Whether that's through questionnaires, whether that's through just simply asking, how's this affecting you emotionally? Are you feeling worried about this? Are you feeling sad about this? Are you feeling in control or out of control? You know, these empathic, person-centered questions that can just elicit an understanding of their mood state. And perhaps lastly, has there been trauma? And we're
Yeah.
talking emotional trauma, social trauma, bullying, workplace trauma, sexual assault, good parenting as a kid, poor parenting as a kid, attachment, all of the social security, financial security, all these
Mm.
things, just to understand that setting that the person's in, their life setting, because that's, again, sliders. When those things are kind of off optimum, you might think of them as sliders that take you towards these nociplastic and central mechanism more so.
Mm. Yeah. I love the way that you gave that sort of conversation starter, if you like, which is, you look at the scan and this is good news, and scans don't show everything, and that gives you sort of the in, doesn't it, with the patient into talking about the nociplastic pain and the different types of pain that could be presenting that wouldn't show on a scan.
Yeah, it is tough though. I mean, definitely we don't, these messages don't always land. We certainly will
Yeah.
get who say, well, if the ordinary MRI scan is normal, can I get a super duper MRI scan? You know,
Yeah.
super high resolution type idea. And I think many people really struggle with this idea that why can't you see it? If
Yeah.
you can, if you can build supercomputers and you can put man on the moon and you can go to the far side of the moon, all these things, why can't we see this problem?
But I'm really curious to know that if somebody does say that to you, Ben, this is sort of tied in with our last question, really, which is for clinicians that are seeing this kind of thing regularly. What's a really practical clinical tip for somebody that says, "Can I have the super scan?" What do you say to your patients if they come to you with that?
I think you can sort of say, look, at the end of the day, pain is an experience, in the same way that me sat on this second floor room looking out across a bit of a car park and the Dyson Cancer Centre over there, like I'm experiencing this. And we don't know how we experience things. We don't know how we are conscious in the moment. We don't understand
Mm,
human function to the level that we can kind of understand consciousness and conscious experience. So I think maybe we've got to say, look, this is a gap in our knowledge. We do not understand this fully. What we
yeah.
do know is all these things contribute, and in some way, our system is super good at giving meaning to all of this relevant input. It may be
Mm,
that your system's giving meaning, and that if you like, the end result of that decision making is this situation you're currently in is somewhat threatening. And the
mm,
best thing to do about this is to warn you about that threat by producing a pain experience.
mm,
Doesn't mean it's not real, but it means it's complex.
mm,
So if we can unpick all these things that are sort of contributing to that sense of needing to be on alert, and that might be psychological things that are outside of your scope, my scope. We need psychological support.
mm.
It might be social support. We might be thinking about housing and job security and caring roles. How do we help that person bring that level of sensitivity down?
Yeah. Yeah, brilliant. Thank you. That's great. Great answer. There's a really brilliant question here actually from Beth Owen. Um, and she says, do you explain normal age-related changes?
Yeah, totally, absolutely. And I don't have the figures to my head or in my hand, but yeah, absolutely, Beth. Those, on in a 56-year-old, you'll find disc bulges in 80% of people who never reported back pain. I'm 52. I
Mm,
don't want to have an MRI of my spine. I've never had one. It's going to tell me stuff I'd be better off not knowing. So absolutely, normal age-related changes, I think, are great phrases to use, and make a bit of a joke about it. Oh, these radiologists always say degeneration. That sounds such a scary word, isn't it? What they
mm,
mean is change is normal for your chronological age. And of course, people are surprised that actually those changes become observable 30s onwards, not just 60s onwards, but like certainly in a time in life when people don't feel old.
that's a comfort, isn't it? To to just mention that the changes start from your 30s, but the less fear around it in your 30s than there may be, say, in your
Yeah.
80s.
I tend to make some jokes about it, like, your face is a little bit more lined than it used to be, your hair's a little bit grayer, or you've got less of it than you used to be. Those are pain-free age-related changes.
Safe. Yeah.
Kisses
Yeah.
of time. Did Beth have
Yeah.
another question? I've not got the Q&A up
I
here,
think it was a
actually.
statement, really. And Beth says, I don't feel it's helpful for a patient to believe there's nothing wrong, i.e., their spine is perfect. The reality is changes are very present since teenage years. That's pretty much, yep, exactly what Ben's just said. And management is maintenance rather than fixative. This helps the mind if the patient engages with the body.
Yeah, that's really true. I like that last bit, engaging with the body, Joe, because I know you've sort of got practical, almost like, how do we manage this? And I think it's that engaging with the body. I think when people have got nociplastic pain, or pain that
Mm,
is predominantly nociplastic, let me rephrase to follow my own advice. It's really common that people have become aversive of or avoidant of, day-to-day life, exercise, stretches, things that are provocative, because you haven't got a clear explanation. Really
yeah.
sensibly, you don't want to make it any worse, so you don't want to do the wrong thing. So what do? You life gets smaller, and the map of your life gets a little bit smaller. I think as clinicians, a hugely important part of our role, there's lots of parts to managing maybe nociplastic complex pain, but a physical thing is, how do we get them to engage in their body again, use their body again in that sweet spot? I know Tasha Stanton will talk about the sweet spot for OA management, but like not too little, not
Yeah.
too much. Where's the sweet spot? Where's that Goldilocks zone of just the right amount of movement? And that could be Pilates based, yoga based, Tai Chi based. It could be in the gym. It could be weight training. But it's like not weight training like you did 15 years ago or 20 years ago, but recognizing this is where you are now. And the fact that these imaging things don't show fractures and arthritis and bad things is, you're really unlikely to do yourself any damage. You're highly likely to flare pain up if you overdose that exercise. But if you can just find that right level, and that's where our clinical expertise and guidance perhaps is crucial, you buttressed up the education and the sort of physical rehab, exploring your body, getting fitter, getting stronger. But that there's something, and Joe, I don't think this has been researched, that confidence in the body, that subtle confidence in the body where you just begin to kind of go, I can do this. And I can have control over grading that exercise slowly but surely back, and then life gets a bit bigger and social connection perhaps becomes an option and work becomes an option, and perhaps some of those other contributors can sort of be down regulated at that point.
Interesting. Yeah, I hadn't thought of that. Really interesting. Thank you, Ben. Irene, we have time for your last question just before we finish. And Irene says, is arthritis different to age-related changes?
If you're talking about osteoarthritis, no, I'd say that's pretty much synonymous. I mean, you can have clinically significant, if you like, age-related changes. We'd call that, there you go, you've got an osteoarthritic knee with no joint space and knee replacements appropriate. But that's a sort of spectrum, and I think when you're at the lesser end of the spectrum, just being able to say, you've got the spine of a 50-year-old, brilliant, that's exactly what I'd expect, assuming they're 50. That's great. There's nothing sinister about this. There's nothing catastrophic about this. But no, I think you should recognize and validate that, of course, the body changes. This is normal, but it isn't predictive of necessarily pain or functional impediment or need to overprotect and to stop hobbies and sport and work and social life.
Yeah, brilliant. Thank you very much.
Imaging, to full circle, Joe, the imaging is one part of this picture, one part of the puzzle.
Yeah, and I think that is the important thing here, is to sort of remove it as being the main part of it, because there's all the other information that is part of what's presenting in front of you, and helping your patients to understand that it is just one, it's a small part of the process of diagnosing and rehabilitation. Fantastic, Ben. Thank you so much. Really enjoyed that, and I think everybody that's watching has really enjoyed, because they've all stayed. You can always tell. And we've had some lovely questions.
Thank you for giving up lunch times or breakfasts or late evenings. It's really appreciated.
Yeah, thank you. So for any of you who are interested in doing a deeper dive with Ben, I'm sure you've got a sense today of his teaching style and just how completely knowledgeable he is about absolutely everything. You can ask him anything. And no, I mean that seriously, that he does have a real skill for making complex understandable. So if you are interested in spending a couple of days with Ben, going into all this in a much deeper way, then he has an Explain Pain course on the 9th and 10th of July. Could you just tell people, Ben, if you don't mind, what they would expect to come away with if they were to spend 2 days with you in July on an Explain Pain online course?
I think we try and bring, whoever comes, we try and bring everybody up to a kind of level of the big picture of pain, starting with, I've touched on this, like trying to understand how we're conscious, trying to understand these discrepancies where people can have minor injuries, major pain, but you can have major injuries and no pain. How does that work? We think about the biopsychosocial model and the mature organism model, sort of frameworks to think about these pain mechanisms. We do then go into central mechanisms and neuropathic mechanisms and nociceptive mechanisms. So we kind of go into the science of what leads to those pain predominant mechanisms. And threaded through that, there's nuggets, Joe. There's nuggets of, how do you say this to a patient? What's the metaphor? What's the drawing you might come up with? What's the analogy that you might use to help clinicians talk to patients about these things?
Yeah.
Recognizing that patients don't need the science, patients need the kind of utility of this knowledge, and they need to put that knowledge into practice in some way. So it's a sort of, sometimes I think of it as an old school explain pain course.
Yeah. Brilliant. I've sat in on a lot of Ben's courses, and one of the things that I really like about the way Ben teaches is that you come away with so many practical examples, what to say, how to explain this, how to explain pain, but what to say to your patients, how to explain really difficult concepts in simple terms, just tons of examples threaded throughout the whole course that keeps you engaged, and so many ideas to go away with practically into your own clinical practice. So the link is in the chat. We will send the link out to this recording afterwards, and again there'll be the link to the course if you want to go and have a look on there and see if it might be for you. Then also there are lots of other clinical discussions with Ben on the YouTube channel. Go and check those out if you have liked what you've heard today. Thank you, Ben. Thank you for sharing your expertise with us. And thank you to everybody who has joined us live in this clinical discussion, for spending the last half an hour with us. And if you're watching on replay, thank you for watching also. And we look forward to seeing you again in the not so distant future. Thanks very much, everybody. Thanks, Ben. Take care.